Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week's summaries, which this week were brought to you by our authors Jason Lesnick, Samuel Rouleau, Clark Strunk, Rebecca DeFabio, and Clay Smith. Okay, let's skip straight over to the third article. Titled Efficacy and Safety of Minocycline in Patients with Acute Ischemic Stroke, the Emphasis Trial, a multicenter double-blinded randomized controlled trial published in the Lancet. Alright, so when you have an ischemic stroke, obviously the ischemia is going to kill some of your brain tissue. However, the inflammation that happens around that ischemia is also going to be dangerous for your brain. This is very obvious when you have something like a cerebellar stroke, which often require decompression because there's so much swelling that these patients herniate. However, other ischemic strokes don't usually have that bad a sequelae, but you see how much this affects, the rest of the brain, this inflammation. So if you have an ischemic stroke, and hopefully we're going to do everything that we can to unblock those arteries, but is there more that we could do? Could we reduce the inflammation? And oddly enough, minocycline, an antibiotic, has been shown to reduce ischemic neuroinflammation, possibly through suppression of microglia cells. I didn't look into exactly how this came to be, that people discovered this. I don't think I've ever prescribed minocycline or heard about minocycline being given to anybody. But if it has these properties and we're not using it that much as an antibiotic, then why not, especially if it's helping patients. So this was a multi-center double-blinded randomized controlled trial out of China that recruited just over 1,700 patients with acute ischemic strokes and IHSS scores of 4 to 25, so a good range. These are patients with real strokes too, and then it had to be within 72 hours of symptom onset. Now they compared 4.5 days of oral minocycline to a placebo. And the primary outcome was excellent neurological outcome, a modified Rankin scale of 0 to 1 at 90 days, which we saw occurring in 52.6% of the patients that got minocycline and 47.4% of the patients that got the placebo. This was a statistically significant difference, so we actually see some better outcomes due to minocycline, which is great. Now, this effect was most prominent in the patients who had these excellent neurological outcomes. However, we look at the more typical stroke ranges, usually 0 to 3, which is patients that are going to still have some disabilities, but are often able to function mostly on their own, then even that distribution favored the minocycline group. So this is actually really interesting stuff. However, from this data, it doesn't look like it's necessarily going to be something that we have to give up front with aspirin, because the median time to the first dose of minocycline was 41 hours. So it's not like they were that quick on the ball for this. And this trial also didn't even show a better effect for a sooner time of administration. And not that I care that much about C-reactive proteins, certainly not in this circumstance, but those were also reduced by the minocycline. So it seems plausible that it really is acting by reducing the inflammation. Now, this, of course, is going to have to be repeated in different populations. We wanted to generalize to different people in different countries. And of course, all data just needs to be repeated, but this is very interesting. I'd be very happy for this to change my practice if it's bettering the outcomes of my patients, and there's not going to be a lot of downsides to a couple of days of minocycline. So in a spoonful, minocycline represents a very promising treatment adjunct in acute ischemic stroke management. The timescale doesn't make it look like anything that we'll be giving emergently, but neurology can start it on admission and hopefully improve the outcomes of our patients. And then the fourth article, more stroke articles, titled The Tenecteplase versus Standard Medical Treatment for Basilar Artery Occlusion Within 24 Hours, the TRACE-5 study, published in the Lancet as well. Now, if you remember your neuroanatomy, you know that if you close off the basilar artery, then you've cut off a lot of blood to your brain. The morbidity and mortality rates for this kind of thing are 80 to 90%. And so it's really something that you need to unblock quickly if you want to have any kind of decent outcomes. Now, these are the cases that, as we talked about, even from the guidelines, where a thrombectomy out to 24 hours is very clearly beneficial. However, in these circumstances, the use of thrombolysis is not necessarily as clear. And it would be important that we had this well established that you could give thrombolysis because, according to this article at least, only 3% of the global population actually has access to EVT. And so there's a huge percent of the population that are potentially getting these devastating strokes and have no access to EVT. And a lot of places are not going to necessarily have advanced imaging either. So if we could make it kind of the standard that if you have a basilar stroke within 24 hours and you can give thrombolysis, excellent, you should be doing that. But we haven't actually seen that in trials. And so here is that trial. This is a prospective randomized superiority phase 3 trial, which was conducted in 66 centers in China. And they investigated whether IV Tenecteplase within 24 hours of ischemic basilar artery occlusion strokes compared to just standard medical management, which is to say that if you came in after 4.5 hours, you were getting nothing if you didn't have access to EVT, and versus giving them Tenecteplase. And what they found was actually quite striking. At 90 days, 38% of the patients in the Tenecteplase group had no disability, so a modified Rankin score of 0 to 1. This is compared to 29% in the standard medical treatment group. So again, 38 compared to 29%. This was statistically significant. This is a big difference. And accompanying that big difference was not a big difference in adverse events. The rate of symptomatic intracranial hemorrhage was 2% and 3% at 36 hours, which was not statistically different between the groups. The surprising part, however, is that despite a lot more of these patients doing a lot better, the 90-day all-cause mortality was not significantly different between the two groups. And so what is driving all of this? So what is really driving the difference here? About equal proportions of these patients got thrombectomy, 51% and 48%. But in the standard care group, only 35% of patients got thrombolysis, compared to that being the intervention in the Tenecteplase group. So a big proportion of the standard medical management group just watched their patients have massive debilitating strokes. And even while the standard medical management group was getting alteplase, this isn't really a comparison of different lysis types because so many of those patients presented past 4.5 hours and so were not getting thrombolysis at all. And so when EVT wasn't available, they got nothing. However, in the Tenecteplase group, all the way out to 24 hours, they were still at least getting Tenecteplase. And if your mortality rate is 80-90%, then heck yeah, throw the kitchen sink at it. This could be an important change in stroke management, assuming that it generalizes well and we get other trials on this. This is very interesting. So while in the guidelines, this is a possibility, but only as a 2B recommendation. If more data like this comes out, then it's going to have to be upgraded. And it doesn't necessarily have to be with fancy scanners where you see the ischemic penumbra, but maybe in all comers. This is a big deal for stroke management. In a spoonful, this evidence is strongly in support of thrombolysis with Tenecteplase for basilar artery strokes all the way out to 24 hours. Okay, that's all the articles from this week. What did we learn from this week? Let's talk a little bit about them. And then from the third article, the antibiotic minocycline shows a small but consistent benefit in stroke outcomes, likely through inflammation modulation. And then from the fourth article, more and more indications for thrombolysis. This trial demonstrated that up to 24 hours out for basilar artery occlusions, we were seeing major benefit here. This would expand care options for those who do not have access to thrombectomy, which, if it is available, then they should still get that. All right, now if you're hearing this right now, then you are not a part of the members feed and you missed 3 articles that we covered from this past week. What did you miss? Well, we talked about the AHA's new stroke guidelines. We talked about whether NOACs are really better than warfarin, even for different types of embolic phenomenon. And then we talked about Tenecteplase. Could you use it up to 24 hours in patients without large vessel occlusions? Links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.